the knee is kind of just like a middle child. It just get, blamed for everything. Right. And then that's the result because the knee only, just flex, extend, doesn't have that much rotation. We go take them through like passive like hip flexion and you see like, oh, why is he going or she's going external rotation with that? So if they do have those signs, right, what is something that they can do right now to actually, prevent that from getting worse?
Yeah. So you can certainly get range of motion through the hip joints, right? And so while you do have the mechanical conflict of the bone, there are a number of factors that add to hip range of motion. So you can get hip range of motion through your muscles, through your tendons, and we call that the soft tissue layer. So you really want to maximize your range of motion flexibility through the soft tissue layer. I would say is sort of just a nice, safety net for therapists, but therapists like yourself, with the caliber that you have, you don't really even need my protocol. My protocol, is just the destination, and you're able to sprinkle in all the things that you need to sprinkle in. The reason why I came up with a protocol is that physical therapy is so key to my, to the surgery and to the recovery. And it's something that I try to enforce on patients early on. When I agreed to do the surgery, I tell them, look, you're going to have to really lock in on physical therapy. I'm a good surgeon, but I'm not a magician. And you're going to have to do the PT in order to.
All right, everyone, welcome to another episode of the Myokinetix podcast. Today we have Dr. Benedict Nwachukwu from Hospital for Special Surgery. And Dr. Nwachukwu is just extremely world-class when it comes to hip pathology, and that's why we're here today. He is one of the co-clinical researcher for orthopedics at HSS. What's really impressive about Dr. Nwachukwu is that he was a college athlete himself. He played all 4 years in basketball. He got his Harvard medical degree and as well as an MBA. So we can learn a thing or two from him besides just all the common orthopedic stuff. So Dr. Nwachukwu, thank you so much.
Yeah, thank you very much for having me. I appreciate the very kind introduction.
Yeah, so, obviously, we can go in more detail. So can you tell the listener about your background? What drive you to be a surgeon?
Yeah, so, like you mentioned, so I played basketball. I actually was born in Nigeria, grew up in the UK, in the United Kingdom, and then I came over to a prep school in New Jersey to play basketball. I was recruited there. Over the course of the years, I had a few injuries and things like that, knee pain. And I had the opportunity actually as a college sophomore to shadow Dr. David Alchek here at HSS. And at that point, I decided that, orthopedic patients, sports medicine patients in particular, were some of the happiest patients that I'd seen in medicine because they come in with an injury, they go see their doctor, they get fixed, they get back to doing the things that they want to do. And so at that point, I decided I wanted to be a sports medicine surgeon. And, just given my passion for basketball, I wanted to eventually take care of athletes and get people back in the game. So, I would not even consider what I do on a day-to-day work. It's really just fun for me.
Yeah, I love that. So when in your athletic career, right, as you were playing basketball, what were some things that you personally went through yourself that influenced who you are today as a surgeon?
Yeah, it's so, I had patella tendinitis. It's such a common injury for basketball players, jumper's knee. And at the time, it was something that I think, maybe wasn't handled the way that it's supposed to. So it was supposed to have been handled. And, truly, I think that it did hinder my ability to play at the highest level. And so I'm always now motivated to make sure that, our athletes get the highest level of care. And then the other thing, a little personal tidbit about me. So I actually have hip impingement. I have bilateral cam deformities. And so when I was coming up, people didn't really diagnose it. And, I had groin pain and I couldn't squat as low as I wanted to. And I was really stiff. I just thought that I was just a stiff guy. But it was really my hip impingement. And so, the technology just hadn't caught up and we just didn't have the knowledge, in the early 2000s to help me. And so, as a result of my experiences, I'm very motivated to manage people with hip pain and hip impingement.
Mm-hmm. So funny you mentioned that because last week we did a podcast with a professional soccer player who used to play at the highest level, Man United. And he has to cut his career short after signing with like Sir Alex Ferguson and everything else and went through 6 hip surgery. So can you tell me a little bit the history of cam impingement?
Yeah. So What we are finding through our research is that cam impingement is actually something that can be helpful when you're young, right? So you grow this extra bone, and it basically forms during your growth phase, right at the growth plate on your femoral head. And there's some data that it basically creates a better lever arm, and it can help you to be a little bit more forceful with lower extremity sports, things like soccer, lacrosse, basketball, you name it. But there is this mechanical conflict because it's extra bone. And so what happens is if it gets left unchecked and unmanaged, it can lead to a labral tear, and it can lead to arthritis. So oftentimes what we see is that when it's undiagnosed, and the time that people come to see me in the office sometimes, it's a little too late. And that's when you have to have 6 surgeries because you try a salvage arthroscopy, but the person has too much arthritis at that point. Then you try things like a reconstruction, and eventually you might have to get a replacement. And so, we work very hard to diagnose the impingement up front and try non-surgical modalities. So make sure that you're strengthening the muscles around the hip in order to offload the joint and to minimize the impact of that impingement. And then oftentimes, if that doesn't work, then we will think about ways to preserve the joint so that you don't go on to damage the cartilage.
What are some common telltale signs of like early stage where they can be like, oh, this could be a cam impingement?
Yeah. So one of the things that I do for my athletes is I do a screening exam of their internal rotation.
Mm-hmm.
So some people are what we call obligate external rotators, which means that to flex their hip, they have to externally rotate it because they can't internally rotate. That's a telltale sign in an athlete. And then we look for internal rotation, and we'll screen the internal rotation. Now, there are some subtle telltale signs, and my colleague, Dr. Williams, and I have been working on this. So recurrent ACL injuries is actually a telltale sign. And the reason being is that when you don't have the range of motion through your hip, you actually put more stress on your knee. And there's a study that was published by Dr. Brian Kelly in 2017 where he looked at NFL players and he screened them based on their hip range of motion. And people who had stiff hips had a 6 times increased risk of tearing their ACL throughout their NFL career. And so if you fail an initial ACL surgery, Dr. Williams will screen you for hip impingement and have you see me. And then the other telltale sign that's more subtle, clinical telltale sign, is a young athlete who has a disc herniation. Because you're a young athlete. There's no reason for you to have a disc herniation. You have good collagen. But similarly, while the knee is downstream, the lumbar spine can be upstream. And so if you don't have the range of motion through your hip, then you're more likely to herniate a disc in your spine. And so, treat the spine, but then also check the hip.
Yeah, no, I love that because when we do our screen, especially when it comes to ACL, those are the thing. We always look the joint above and below. And I always say like the knee is kind of just like a middle child, always just get, blamed for everything.
Right.
And then that's the result because the knee only, just flex, extend, doesn't have that much rotation. To just hear you say like, yeah, we're screening, especially when we go take them through like passive like hip flexion and you see like, oh, why is he going or she's going external rotation with that? So that's huge. Now, if they do have those signs, right, what is something that they can do right now to actually, prevent that from getting worse?
Yeah. So you can certainly get range of motion through the hip joint, right? And so while you do have the mechanical conflict of the bone, there are a number of factors that add to hip range of motion. So you can get hip range of motion through your muscles, through your tendons, and we call that the soft tissue layer. So you really want to maximize your range of motion flexibility through the soft tissue layer. I'm a huge proponent of things like myofascial release, working to lengthen the muscles and tendons, stretching. All of those modalities can be very helpful. And then, like I said, focusing on a strengthening program where you're really working on strengthening your glutes and the soft tissue around the hip to offload the hip joint.
Yeah, I love you saying that because every time we have someone that has really no serious injury, we kind of look at it as like, hey, this is a good blessing. It's like check engine lights going off. We actually get to do something about it. Nothing is broken down yet. And off camera, you and I were just talking about, the common myth that I usually hear in the old school PT realm is like, once you have an impingement, you're going to need hip replacement down the road. So your main research and your main niche now is just hip preservation. So can you tell the listener about that? Like, what does that mean? Like, what's the hip preservation program entail?
Yeah. So Hip preservation entails a number of modalities to preserve the joint to prevent the hip from progressing to arthritis. So it is a myth that just because you have a hip impingement that you're going to have arthritis. You can avoid arthritis through just maintaining a healthy lifestyle, healthy weight, and strengthening the muscles around the hip. Now that's offset by your desired activity level. So if you have hip impingement and you want to maintain a very high level of activity, you do have a slightly higher risk of worsening that mechanical conflict and injuring the labrum. And so that's when we have a shared decision-making process with our patients and think about some of the surgical modalities. So the two primary ones are arthroscopy, which I do, which is where you put a camera into the hip. You will repair the labrum in order to restore the suction seal to the hip and to essentially heal the cartilage, because the labrum is a piece of cartilage. And then we'll do what's called a femoroplasty, which is where we shave down the cam. And the cam is the extra bone that tears the labrum. I oftentimes think of the labrum as an innocent bystander. It's really the mechanical conflict on the cam that's the problem. And so we'll do that primarily. And then, if there's evidence of joint wear, we'll do things like inject stem cells and things like that at the time of surgery. And then so that's arthroscopic. And then there's the open preservation options. And so depending on the things that are leading to the mechanical conflict in the hip, some people have dysplasia. So if they have dysplasia to the point where they would not benefit from arthroscopy, they can have what's called a periacetabular osteotomy, or PAO. And as part of that, you will cut the bone around the pelvis and reshape it. And so that's for a select population. And then sometimes we'll also do what's called a femoral rotational osteotomy, which means you'll cut the femur in order to rotate the hip. But I would say that the bulk of people who need hip preservation surgery really have the arthroscopy.
Okay. Now, can we talk about timeline for rehab? Like, so let's say they do underwent any of these kind of surgery. Like, what's the timeline until they start slowly getting back on the field?
Yeah. It's very variable, to be honest. And, I've had a professional athlete get back to play 4 months after hip arthroscopy. And I would say that's probably the very earliest. And, on the long end, sometimes we can see it take 9 months to a year for people to get back to the highest level of activity. I will say that I think your prior pre-surgical level of function is most predictive of how long it will take you. There's been some studies that show that people who have, good hip extension strength, so, primarily through their Gmax, are the people who have the shortest rehab times after hip arthroscopy. And so, my protocol is pretty regimented, and I put my protocol online. It's on my website, manhattansportsdoc.com, and I basically take patients through a regimented protocol. So the first 3 weeks they're going to be on crutches, partial weight bearing, and that's really to help the tissue heal. And then they'll progress through range of motion, strengthening protocols. Depending on how they're doing, I can let them start running at around the 3-month mark versus the 4-month mark, anywhere between that time frame. And as they progress through their running program, then we'll start to introduce sport-specific activity. I would say the middle of the bell curve, most patients can expect to get back to their sport in around 6 months.
By the way, I love your protocol. It's probably one of the most detail-oriented one that we see. So when we get patients from you, we're like, this is great. I was like, we just literally just follow the guideline. And then we'll sprinkle some stuff in there. Like the new thing we've been doing is now it's just as soon as they can fully weight bear, we get them to go on the force plates. And immediately we can literally tell the patient, like, hey, you're unloading on this hip way early on this one. So there's a huge delay because, biocycle shows are like your body remember pain. Right. So it's just always constantly pain avoidance.
Yeah.
Right. And typically when I see any cam impingement is almost always bilateral, but then one side is almost asymptomatic and the other one has like way more pain. Right. So one of the patients that you and I are currently working with together is when we put him on a force plate, it's like, oh wow, like he's still not weight bearing on the left side as much. So let's address that before we go back to even, the running protocol. Because, I look at pain and traumatic injury and I look at any sport related injury as trauma. And, you're going to have some sort of baggage with you.
That's
and
right.
What we need to do is, again, reinforce. And all I say is like upgrade their software. It's like an iOS software that needs to be upgraded so that we can keep up. Because the hardware stuff, you already did all the work.
Yeah.
It's healing, it's looking good, but now the brain just needs to kind of trust that body again.
Yeah, no, and and a plug for you. Every patient that I send to you, I fully trust you to implement it. And the rehab protocol, I would say, is sort of just a nice safety net for the therapist. But therapists like yourself, with the caliber that you have, you don't really even need my protocol. My protocol, is just the destination, and you're able to sprinkle in all the things that you need to sprinkle in. The reason why I came up with a protocol is that physical therapy is so key to my to the surgery and to the recovery, and it's something that I try to enforce on patients early on. When I agree to do the surgery, I tell them, look, you're going to have to really lock in on physical therapy. I'm a good surgeon, but I'm not a magician, and you're going to have to do the PT in order to recover. I would say 98% of patients buy in, but some patients, they think that you do the surgery and, they're healed. And the PT component of it is really critical.
Yeah. So the one thing I would say your superpower, based on all the feedback I got from all the patients, is you're just so involved and you care so much about them. So like what drive you every day? Like what made you get up at 6:30 to come do a podcast, to spread your message? Like what's the key thing for you?
Well, I appreciate you saying that. And before I answer that question, it's funny. I was meeting with my wife over the weekend. We just had our firstborn.
Congratulations.
Thank you so much. And I guess there are three types of parents, she was telling me. So there's an elephant parent who is in touch with the emotion. There's a tiger parent who sort of drives the baby, and then there's a helicopter parent. And I was raised in a tiger home, and my wife was like, what type of parent do you think you're going to be? And I'm like, I'm probably going to be an elephant and like be in touch with the emotion. But really, I know that I'm probably going to be a tiger in a helicopter. And so that's kind of how I take care of my patients too, is that, it's a little bit of tough love, when they come in, if they're not meeting their milestones, and, a little bit of helicopter where, I will check in with them after the surgery. They can always message me in patient portal, send an email. I'm always involved. I ask them to send me pictures. I ask their PTs to reach out to me, and I respond to every email. To answer your question, I don't know. I think I'm, a little bit of a micromanager, but when it comes to your patient outcomes, it's a really good trait, I think, because you tend not to miss things as much. And I also just really care. I want to make sure that my patients have the best outcome. And, as someone who's had, sports medicine injuries myself, I had my Achilles tendon repaired when I was in medical school. I know what it's like to be a patient, and I know that I really appreciated my doctor checking in and caring.
I'm willing to bet when you're on the court, you're definitely that guy that just like, hey, we're down 15. Hey, I need you to do this. Yeah. I need you to do this. Hey, let's get it together. How's that personality as an athlete, like transform who you are right now as a surgeon?
Yeah, I think it really helps. It really helps, right? Because as a surgeon, unfortunately, the buck will always stop with you, right? So if I do surgery and a patient doesn't get good PT, or something happens, ultimately, it's my surgery, and you sort of have to take responsibility and ownership over it. And in athletics, it's the same way, right? If your team loses, right, you're not going to say, well, our star player, had a bad shooting night. You lost, the team lost, and you should have done something to help the star player, whether that's, more shoot arounds, etc. And so that mindset has always been, I think, has been very helpful. And then sort of also the Kobe Bryant mindset where, you can't, fixate on the losses and things like that. You just got to keep on shooting, and, allows you to maintain a positive attitude as you go through and be your best self for your patients.
Yeah, the one thing we're big on at my clinic, Myokinetix, is we utilize the Maslow hierarchy of needs a lot, because once a patient who's an athlete get injured, their identity is gone, right? And then next thing you know, they're not with the team. They no longer have that camaraderie that they used to have, and especially if you're a star player, the team used to count on you. You used to be the guy. Now you're sitting on the sideline. Since you're used to, you're involved with professional athletes right now, and you've seen people goes up and down. What are some advice to some of the athletes right now that's going through that like they're in the dark tunnel? they just got surgery, they're laying in bed, and they just question whether they're going to get back to it? Like, what is something you would want to tell them?
Yeah, I think that people sometimes feel like they have to go through things alone. And I would just counsel the athletes who get hurt to make sure that they reach out to people, build a support staff around you. I think that if you're on a team, you have that inherently built in, which is nice, but don't isolate yourself from the team. So sometimes we'll see athletes who are on teams, they'll get hurt and they'll, sort of go away from the team. But that's really when you should be present and be around, because that being around the team will help buoy your spirits. And that will be a built-in support staff. And, one of the things that, and this is more for therapists, one of the things that, we have looked at is the idea of kinesiophobia. And it's just the idea that, people can be scared of their joint after it's been hurt, because you don't know why you tore your ACL, why you tore your Achilles. You were just running down the court and all of a sudden your Achilles popped. And so some people, that can affect how some people either get back into sport or how they move. And so I think it's really important for therapists to identify that early on, and for patients to identify that for themselves early on, because there are things that you can do to recondition and to minimize that kinesiophobia.
Yeah, I think I actually just mentioned this yesterday. Every time when we have athletes going back to the field, before we send them back, we always try to mimic certain situation they were in when they get hurt. And we just run that tape over and over and over again until they feel like, okay, I feel comfortable. I grew up a Giants fan, so I remember when Victor Cruz came back and he scored a touchdown, same end zone, same route where he tore his ACL, and he just got down, pray, cry a little bit, and say, hey, listen, I overcame that. So that's great. Now, just talking to you, I feel like you would be such a good coach. Now, do you ever have any interest in coaching down the road, or what's the game plan here?
Yeah, so I mean, I would love to coach. Honestly, I would love to coach. I haven't seen the opportunity, but my long-term plan is to sort of get involved in like youth sports through my son, and if there's like a rec league or something that or like a JV league that I can coach, I would love to coach. I don't think I could ever professionally coach, but would love to coach. And I think coaching is such good mentorship. I know that the coaches that I've had throughout the years have been really impactful for me. And I know that there's a lot of young men and young women out there who sort of need that extra mentorship, potentially outside of the home too. And sports and coaching is a really important way to do that.
Yeah, I always tell parents that we get to talk to that I congratulate them in putting their kids in sport, because I moved here from Thailand, and when I got here I didn't have like a big friend group, but through like soccer, lacrosse, all the sport I get to play, I actually get to build some, like, I'm still really close with two of my best friends from high school just through sport. And I think giving your kids opportunity to play sport, it teaches them how to deal with adversity and setback, right? Because you and I know that we live long enough, you encounter more adversity more than anything, and then nothing in life ever goes as planned. And the one thing we always remind the team that we have is that this is probably the first time our athletes deal with real adversity, where they have to face this. They have great support system in the family, but at the end of the day, they have to show up. They still have to do the work themselves. And the one thing that's so rewarding for us at the clinic is to see a transformation from like an adolescent into like a grown adult, when they come up at the end of the tunnel, right? We have, not to date myself, but like a couple of years ago, I got my first like wedding invite from one of my athletes. I'm just like, bro, I know you since like middle school.
Yeah.
Now you're doing this. It's kind of wild. So like you've been doing this for a long time. Now, as far as seeing the shift in your patient, what made you smile the most when they come in to see you?
That's great. So two things. So the patients who come in for their 1 year check, so I always joke with my staff that typically we don't see a lot of 1 year patients, even though we ask them to come in. But patients patients they go off and they live their life, right? So you see them at 6 months, 9 months, and you're like, okay, go off and start playing the sport, and come back at your 1 year mark and check in with me. Send me a picture and let me know how you're doing. Send me a picture from your sport. And oftentimes they don't. They'll just forget about you, right? I know that sounds like, oh, poor me, my patients forget about me, but it's true. Sometimes when I talk to patients and they've had surgery 3 or 4 years ago, I say, oh, like, who did your surgery? And they will forget. They're like, oh, Dr. Smith in Newtown. They just don't really remember the surgeon's name. But the patients who come in at a year who are like, I'm doing great, and I just want to thank you. It means so much, just because it lets me, it's just a validation, and it's very rewarding. And I love that. That always puts a smile on my face when I see that.
What I always have this, and with many renowned surgeon I get to talk to every day, we always want to see, I feel like medicine needs a little bit more touch point, especially post-op for us, like for our ACL, for example. We always try to have a month check-in, like actually after 12 months, because, it takes 2 years to actually truly recover. New research just came out that, a year and a half after ACL surgery or any traumatic surgery, there's still that tentativeness, right? Because again, it's kind of like, Peter Pan and the whole shadow thing is always just creeping up, right? So if some of your patients listening to this, what would you say to them that you haven't seen them in over a year? How would you pitch that to get them to come back to be like, hey, let's check in?
Yeah, come back, check in. Just because you're back to sport doesn't mean you're back to a high level of function, right? And so, we have data when we look at return to sport. It's no longer about return to sport. And, I'm actually pretty rigorous about, clearing people to return to sport. We'll send them through a battery of tests to make sure that they're able to return to sport. But even when you return to sport, there is, a questionnaire where it's, are you playing at the same level that you were prior to injury? If you are, why? If you're not, why? And there's still things that you can troubleshoot, right? Where you can try to understand why people are not, at 100 if they're at, 90 or 95. And, sometimes, people are at 95, but we can always help to troubleshoot and optimize the outcome.
Another thing I would want to add to that point too is that once athletes go back, they usually ended up playing up. So the intensity just gradually get more and more. So the demand that you used to have 2 years ago when you got hurt versus now is much better, right? And you've been in, the field of sports for so long. What have you seen so far, the trend of sport, especially like we talk about rotational sports all the time because that's when they get this hip pathology a lot. So what are something that you have seen within the past 10 years that might be a factor to, seeing more and more hip pathology?
Yeah, so I think that people are playing sports younger and younger, right? So they're starting sports younger and younger. And, we know that hip impingement, calf impingement, it primarily starts in adolescence. So we're seeing more adolescents have hip pathology. Yesterday, I operated on 2 teenagers, right? And so we're seeing hip pathology just creep out younger and younger, in part because of just the increased participation in sport at a younger age. And then the other thing that we're seeing is just the intensity of sport participation. So a lot of my adolescent young athletes, it's a year-round thing for them. And I think that contributes to a little bit of overuse. So oftentimes people will think of overuse as being primarily something for the soft tissues, the tendons, but you can certainly get overuse pain and pathology in the joints. And especially if you have a small labral tear, if you're doing your sport year round, you can irritate the labrum and potentially make the tear worse.
Okay. Well, you're a new dad. So, you're clearly, I know your child, you're going to be involved in some sort of sports. So what's the game plan you have right now going into that as far as like planning the athletic career?
Yeah. So my son is 5 weeks and he has a basketball in his crib right now. No, no, look, I think it's, I don't, as much as I said I was going to be a helicopter dad earlier, it's about allowing your child to choose what they want to do. And my goal is to expose my son to as many sports as we can, as this, the after school programs allow. And then, let him choose. That's pretty much what happened for me. So growing up, I played soccer, I played rugby, and I played basketball. I tried to play cricket, but I wasn't very good, and it was kind of boring. And I was good at rugby and basketball, and so I stuck with those two. And so there's going to be a little bit of that where my son is going to probably stick with the sports that he's good at, just because there's some of that external reinforcement from being validated and being a good player. And then for the basketball, I chose basketball over rugby because rugby was brutal. It was I was like showering after a rugby match is really challenging because you're getting raked and you have the cleat marks and just really painful. Basketball was just fun. It was indoor, it was warm, have Gatorade, I was more genteel than rugby. And so I just stuck with basketball and it worked out. So my wife played soccer in college. She's actually a Hall of Famer at her college. And so she's pushing for soccer. I'm probably pushing for basketball, but ultimately, you might play fencing. You might be a fencer. So
could be that.
Who knows?
I love that question. I got one more question for you. Actually, two more. So when it comes to people who are listening and looking to find good PTs, what is some advice you have for them? Because obviously you mentioned PT is crucial when it comes to rehab. So what's on your checklist when it comes to finding good therapists to work with?
Yeah, so I think the HSS does a really nice job of having the HSS Rehabilitation Network. So I think that is very nice as a way, as a sort of a screen to make sure that the place has been vetted and validated. And then even within the HSS Rehabilitation Network, there are certain things that you can look for as a patient. So I would just straight up ask the PT, if they treat people who have, your type of problem, your type of pathology. Specific to the hip, I tell patients that, when they're in their PT facility, they should just look around, look to see who are the patients, right? So, I have patients, upstate, for example, where there's not as many sports PTs, but, they'll go to a place where it advertises a hip PT place, but it's really hip replacements. And so, look around, the waiting room, if it's people who are over 65, it's obviously a great population, but if you're 25, then you that may not be the right environment for you. And then just get the feedback from your surgeon. Make sure that you encourage the PT and surgeon to communicate. That way they can both chart your course together.
Yeah, I love that. And last question. Your favorite pair of Jordans, which one is it?
That's a good one.
There you go. I knew it. I was thinking about this a couple of days. Like, I got to come up with a good question for him.
I don't know which number Jordans there are, but the Jordans that have the two spikes, the sort of shark fins in the front, I want to say like 13s or something. I really love those. They're kind of cool. They have the two spikes. Those are really good. And then absent of that, it would be the Jordan ones. It's just like everywhere, and it's a classic. So
okay, yeah, I bought my I'm wearing the 3s today. I was like, all right, I get to do a podcast. Someone who's like play basketball, he's appreciates a nice pair of Jordans.
Yeah, sure do.
Okay, last question.
Yeah.
All right, bench start cut. Jordan, Kobe, LeBron.
Oh man. I mean, you have to start Jordan. You have to start Jordan, and you bench LeBron, and you cut Kobe.
Wow, I love Kobe. So
yeah, I mean, I love Kobe too. But on my team, you start Jordan. Jordan's gonna win. As long as he's there and he's playing, he's gonna win. And LeBron, arguably would be a really good bench player. And who could he bench play to? Probably Jordan. And Kobe probably would not be a good bench player. He probably would, impact team chemistry. I hope that's not too
fair.
controversial.
No, honestly, it's fair. It's fair. Yeah, it's fair. That's a really good point. Again, love your insight on that. And prediction: who's winning this year?
I know I should say Knicks.
With the Brooklyn Net lanyard on.
Yeah, I know I should say the Knicks because I'm in New York. So forgive me, Dr. Allen. But I think the Timberwolves.
Love the Timberwolves.
Minnesota Timberwolves. Shout out to my boy Kelechi Okoroha, who's the team physician for the Minnesota Timberwolves. They've been doing a great job.
Great job. So, hey, listen, thank you so much. This is such a fun podcast for me to do. I cannot wait to keep working together with you, just help more patients. And I appreciate your time.
Absolutely. This has been great. Thank you so much for having us.
You got it.
Yeah.